research that's been published in the literature already in ASD, one which linked executive functioning deficits with psychotic spectrum disorder symptoms such as illogical thought in children with ASD. In other words, that there is greater executive functioning deficits in children with ASD who have more psychotic symptoms in the form of illogical thought. So this is a very preliminary set of findings. These are not published in my laboratory yet, but again, in sharing sort of our thinking about how to understand these comorbidities, this is one important direction that we feel the field may need to go in. It's also interesting to consider that this notion of autisms as a multitude of variably caused disorders may be very helpful in understanding why some people do and others do not have certain comorbidities in autism. A parallel and very interesting set of work has been done in the field on psychopathy, particularly in adults, which has used phenotyping and basically personality trait psychology to understand two extremely distinct pathways to the development of psychopathy, one of which involves essentially extremely low levels of neuroticism and fearfulness, and the other of which involves very high emotionality, high neuroticism, and poor emotion regulation and poor executive functioning. And there are brain correlates that have been mapped onto these sort of subtypes of psychopathy and different clinical outcomes that are linked with them as well. So an additional area of interest, I think, is to identify at a phenotypic level, are there patterns of traits that individuals with ASD have, which may ultimately help to explain why certain people have high risk for some comorbidities, particularly psychiatric ones, and other people have risks for others or no comorbidities whatsoever. Along these lines, some initial genetic research has been suggesting that some of the same markers for comorbid psychiatric disorders such as anxiety and depression, which are present in people without ASD, are also present in people with ASD who have the same comorbidities. And I would point to Ken Gaddow's work as one example of excellent research in that field. At any rate, a model that Ken and I published a few years ago and trying to understand some of the comorbidity effects also looks at environmental factors. And this is the model, and in short, we're focusing on ASD-related stressors which may produce greater susceptibility to, in particular, anxiety, but other kinds of mood symptoms too, such as anger and depression. The basic idea is that having ASD often produces very specific daily stressors for individuals that other people don't necessarily experience. Some examples are social confusion and unpredictability of social encounters, peer rejection and victimization experiences, prevention of accessing preferred activities, for instance, during school. So the idea is that there's a long, decades-long body of research showing that daily stressors that are frustrating to people increase anxiety, anger, and other negative mood symptoms. And if people with ASD are experiencing a high level of daily stressors, then it might follow that there is heightened anxiety and other types of mood symptoms that are correlated with this. So a dissertation study that's recently been completed in my lab has found both measuring stress at the parent-report level and at the cortisol level is indeed linked with higher levels of these types of mood symptoms as reported by both children and parents. And the interesting question to ask is there a linkage then between this increased level of emotionality and negative mood, and some other more distal effects such as increased social avoidance and avoidant coping and reactive and aggressive coping on the part of children that may explain even a broader swath of psychiatric symptoms, for instance, those in the disruptive behavior domain. This has yet to be determined, but our model would predict it, and we're trying to investigate that further. Very briefly, we've also been interested in the idea that Dr. Scahill brought up about the differentiation between anxiety and autism symptoms per se. So in a paper published in my lab using structural equation modeling, we essentially found that the severity of ASD symptoms, as indicated by things like the ADOS and the ADIR and the SRS, had essentially an almost zero correlation with constructs related to anxiety, separation anxiety, social phobia, and total anxiety based on child, parent, and clinician report. So this was done mainly to investigate the idea that there is this overlap, and yet to what extent do anxiety severity and autism severity actually travel together in the autism population. And this one study suggests that it may be a fairly low level of covariance. Moving on to the treatment research that I've been doing, and I realize I don't have much time, we've been studying cognitive behavioral therapies for both the comorbidity of anxiety and OCD in children with autism and youth with autism, but also more recently, CBT for core autism symptoms themselves. And we had found in earlier work that CBT, when adapted carefully to people with ASD, seemed that it was having some impact on parent-reported autism symptoms. So we followed these early studies up with larger studies using observational measures of autism symptom severity to determine whether CBT might be useful in actually addressing the core features of autism, such as perspective taking, low social motivation, repetitive behaviors, and so forth. And in doing so, we have been concurrently developing a measure to try to personalize the measurement of outcome in this very study, or set of studies. And the idea here is that parents identify 3 top problems that their children are experiencing within the realm of autism symptoms, and then they rate these problems continuously throughout treatment, and ultimately we want to know if these 3 top problems can be improved, personalized to each child with CBT, and secondly, if that improvement is related in any way to broader improvement on more traditional measures like the SRS and the ADOS and so forth. And we've been using videotaping in the home to try to validate this particular measure, and our report is due to Autism Speaks in a few weeks, and fortunately there is good news. There's a lot of convergence between independent coding of these problem behaviors and parents' coding of the behaviors on a daily basis. So the measure looks promising. We don't know how it's going to perform as a measure of treatment outcome yet, but that is coming up. So in the future, it feels like CBT may be a worthwhile treatment approach to continue to assess and potentially disseminate. I recently have published an article on potential implementation plans for any evidence-based intervention into schools and community health clinics due to the dire need of creating access to good quality interventions in our communities and not just leave them in our research centers. So this is IMPRESS in behavior therapy, and I feel that currently the treatments that I've been developing are too preliminary to actually be moving to an implementation stage. However, with the help of NICHD, we are currently testing CBT in a more stringent clinical trial versus an active alternative CBT treatment for the anxiety comorbidity specifically, and this is a 3-site trial, and we may have a clearer idea of how beneficial CBT for children with autism might be at the end of this trial, as well as the ones funded by NIMH and Autism Speaks for core autism symptoms. So my final point is that I think looking towards the future, investigating genetic, neurologic, psychophysiological, neuropsychological, and personality substrates of comorbid psychiatric disorders and ASD may be very beneficial in understanding better how similar are these comorbidities to the same types of symptoms that are in the general population. And 2 examples of this type of research might be functional neuroimaging of people with and without high anxiety in the context of ASD. How much does the brain look similar to people who have high anxiety that don't have ASD, for example? And second, pursuing this idea that executive functioning deficits and stress may predict greater comorbidity concurrently and over time seems like a fruitful direction to perhaps pursue. So thank you for your time.